in entering. So Dennis is the co-lead of the teledermatology program at the Veteran Affairs in the United States, and he's also been the pioneer in starting what's called as My VA Images, which is an app which is provided for direct-to-patient care at Veteran Affairs. Dennis, over to you.
Thank you, Trilok, and to all the organizers for this conference, allowing me to participate and tell you about teledermatology in the Department of Veterans Affairs. For those of you who don't know, VA is the largest integrated healthcare system in the U.S., dedicated to taking care of veterans, and has long had a successful teledermatology program. So my disclosures are that the VA pays a part of my salary, as well as funds some of the research I do, including the results I'll be telling you about today. However, I've been instructed to tell you that the things I tell you about today represent my views and do not necessarily represent the official positions of the Department of Veterans Affairs or the U.S. government. So I'm going to tell you about VA teledermatology, which is a pretty big program, but is almost entirely focused right now on store and forward teledermatology. But I'm going to narrow down the topic, given the time constraints, and focus on two programs and how we tried to implement those, because they tell you something about, I think, the VA overall nevertheless. And I'm going to do so through the lens of implementation science, which is a relatively young field, but has been has had a presence in VA for quite some time and has become more prominent as time has gone by. So this is what access to dermatology looks like for veterans in the U.S. There are a number of different sites of care that are all shown here. Right now, about 80% of all sites that VA delivers care at has access to dermatology, largely through teledermatology. And so those are the green dots. And so that's pretty good, but that means that 20% of the sites do not have access to dermatology. And it's the goal of the VA to convert this map to looking mostly green, over 95% of all sites by the end of 2025. And so that's going to require a big commitment and work. And we'd like to leverage this thing called implementation science to try to help understand implementation and improve it in the future so that we can get more sites to adopt teledermatology. So the goals of implementation science are to promote the systematic uptake of evidence-based practices, including teledermatology, ultimately to improve the quality and effectiveness of healthcare delivery. It is a multidisciplinary field, largely drawn from the social sciences, that includes both frameworks as well as theories and models. Frameworks, I'm going to tell you about two of these, RE-AIM and Implementation Roadmap, which are just basically attempts to organize information and ideas without any attempt to draw causality or relationships between these. In contrast, there are theories, and I'll tell you about one of these, the organizational theory of implementation effectiveness, that do explicitly attempt to draw relationships between entities and suggest a mechanism for how you can do implementation better. So this is a relatively new field, hasn't had a whole lot of application in dermatology, so I thought I'd share this with you today because it's been fun for me to learn. And the idea is that maybe it can help us in dermatology improve how we implement new interventions and also provide a standard way for us to compare implementation programs and results in the future. This is the RE-AIM framework. This is an acronym, stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. It's quite widely used, including in the VA. I'm not going to go through this entire slide, but suffice to say that reach and effectiveness are sort of patient-centered domains, whereas adoption, implementation, and maintenance are more concerned with the process of implementation itself and understanding it. And I'll go through each of these in turn in the context of one particular project that we've had, which is an attempt to deliver VA's standard store and forward consultative model to rural veterans or rural sites that deliver care to rural veterans. This started in 2017. It's still ongoing. We studied the first 2 years of this process using REAIM and have continued to do so, but only presenting the first 2 years, 2017 and 2018. This has been published. And the stipulation for the 16 facilities that were ultimately selected for this funding mechanism was that they had to deliver teledermatology to sites that they hadn't before, that were at least 50% rural or highly rural in terms of their veteran population. And then at the end of 3 years of funding, they were expected to fully implement the program and either be self-sustaining or find other external sources of funding. We used a variety of centralized VA data sources as well as some surveys that we applied directly for this particular evaluation. So we applied REAIM, and so REACH we defined as the number of spoke sites for each of the 16 hubs that was associated with it, as well as the number of encounters and unique patients that were that benefited from this teledermatology funding. And so you can see that the spoke sites increased from 137 to 165 over the first 2 years. And then over encounters and patients, there was a year-by-year increase as well at each of the, across all the sites. We defined effectiveness as the ability of teledermatology to reduce in-person clinic encounters. And this isn't necessarily causal, but there certainly was a inverse correlation between the number of teledermatology visits, which increased over the first 2 years, and the number of in-person visits. So certainly aligns with the intuitive expectation that as you do more teledermatology, you can divert some of these patients from having to be seen in person. And then adoption we defined in one way as the fraction of the total number of dermatology encounters among these rural sites that were seen by teledermatology. And you can see here in this graph in the dark bars that these rural sites had actually higher levels of teledermatology that made up their total number of dermatology consults. And these increased, and these numbers were greater than those in the VA system as a whole. And that's continued to be the case as we've followed these sites. I stands for implementation. And for this, we used a validated instrument called the Stages of Implementation Completion that was originally described by Laura Saldana in 2011. And this is a way where sites can identify at what stage of implementation they're at, ranging from stage 0 at the bottom. I've lost my pointer. Stage 0, where there's been no effort made, all the way to stage 10, where there has been full implementation and that site has enough expertise that they feel willing to mentor and encourage other sites to adopt the implementation. And you can see that after the first year of implementation at our rural sites, there was quite a bit of distribution among the facilities in those light gray bars. They ranged from just preparing to implement to many already having a lot of expertise, but there was quite a large distribution, and this narrowed by the end of the second year, where almost all the sites were fully implemented, and most were ready to mentor other sites. We complemented this SIC instrument with more qualitative data, asking open-ended questions and surveys to the sites, and identified barriers and facilitators. And the top barriers for these sites were staffing, that is, finding enough people to implement and sustain the teledermatology program, and having some of these staff that they did recruit or hire being diverted to other activities, as well as having some difficulty in spending their funds in a timely fashion, and that was probably a more VA-specific thing. There were some facilitators, and the number one factor that came up from many sites was the establishment of sort of formal communications between the end users, the primary care providers, and dermatologists, and making that a little bit more organic. And then the other one was redistributing or streamlining the workflow for primary care providers who had to assume some new duties as they were responding to teledermatology consults. M in RAIM stands for maintenance or sustainability. And for this, we used an instrument that's called the Program Sustainability Index, originally described by Mancini and Merrick in 2004. And this table that you see there is much too complex to go through in detail, but basically it allows sites, by answering a survey, to have a program sustainability score that ranges from 1 to 7. And you can see that overall these facilities had scores that were relatively high, at least 5 and approaching the mid 5s and 6s in some cases. And these were largely driven by two components of the program sustainability scoring, which were leadership as well as staff involvement or collaboration, and that aligned with some of the qualitative data that I showed you in the earlier slide. There were some initial worrisome signs where several sites reported scores that were less than 3, PSI scores less than 3 after the first year, but happily, no sites reported scores less than 3 in the second year and subsequently. So that's the Program Sustainability Index. I'm going to change now to a separate app. Everything I've told you right now has been VA's provider-to-provider consultative store and forward teledermatology model. MyVA Images, as Trilok mentioned, was VA's first foray into performing direct-to-patient teledermatology using a web-based mobile app that was developed by VA for its veteran patients. It interfaces partially with the VA's electronic health record, which is a plus, and it is entirely clinician-initiated. So these aren't patients who are randomly sending photos in, but they are responding to specific requests from their healthcare providers to submit photos, and then those are reviewed by a dermatologist or their provider, who then sends information and instructions back to the patient using the MyVA Images app. So this app was implemented using another framework called the Implementation Roadmap Framework that's been used for some years and promoted by a quality enhancement research initiative within the VA. And this is divided into pre-implementation, implementation, and sustainment phases. So it's a temporally organized framework. And I don't have time to tell you about all of these, except to say I'm going to focus on one pre-implementation activity that we did to look at organizational readiness for MyVA Images, and then I'll tell you how we monitored and evaluated sustainment, implementation and sustainment. So we wanted to look at this thing called organizational readiness for change, which is a component of the organizational theory of implementation effectiveness, which was originally described, the ORC was described by Brian Weiner, and it postulates that the effectiveness of an intervention or of some technological implementation is due to implementation climate. And climate itself is then a function of organizational readiness for change. And that's that box on the far left. And organizational readiness for change is determined by two things: commitment, which is the stakeholders' perception that the organization that they work for has the right values and the right prioritizations to enact a change in the institution. And then there's organizational efficacy, which reflects their belief that that organization actually has the tools and resources necessary to effect that change. So you can, this sounds a little bit, abstract, but you can actually measure organizational readiness for change through a 10-question survey, an ORC survey, and we applied this to our first three sites, which were pilot sites for MyVA Images. And you can see on the right that overall there was a relatively high ORC score of 4, but that among the 3 initial pilot sites there was variation. And one particular site, the one on the bottom, Site C, had significantly higher ORC scores. And it turned out that that site Site C, had significantly higher usages of MyV images. So we're going to try to replicate this data and needs more validation, but we've suggested that ORC might be a convenient and easy tool by which you can use to screen for initial target sites for an implementation program initially. So we looked at implementation over time. The MyV Images app was rolled out sequentially to groups of 7 VA facilities at a time at 3-month intervals. So there's group 1, group 2, all the way through group 4. And you can see that this was largely a story about, unfortunately, the COVID-19 pandemic, which happened sort of during the middle of the implementation scheme. And that's going to figure in some of the other data I show as well. But after COVID-19 started, people started using MyV images at facilities much more significantly than they had before. And this was partly driven by attitudes of the stakeholders involved. And we surveyed many different types, ranging from IT to nursing to dermatology chiefs. And dermatology chiefs at these facilities are shown here. And they had increased or significantly increased interest in using MyV images after the pandemic had started. However, that wasn't enough because implementation was quite uneven among the facilities. And it turns out that those facilities that have been fully exposed and trained and had the MyV images implemented at their sites before the pandemic were much more likely to hit implementation milestones than were sites that were exposed during or afterwards. And we looked at this using the SIC scores that I told you about, and that was also true. They were able to sustain, their ability to sustain usage of MyV images was determined largely by the fact if they were exposed before or whether they were exposed during or after. The ones exposed before were more likely to have higher SIC scores. So that's a really quick tour through implementation science frameworks and one theory. There are many others, but the hope is that, if you can choose one that matches your circumstances and needs, it might allow you to implement things more systematically and allow for more standardized evaluations of implementation programs and results. In VA itself, teledermatology has been very highly implemented, but we still, as I think I showed you in the first slide, have a ways to go to get to our 20 for 25 target. There's a lot of heterogeneity in the system. I showed you about one example of trying to address this in rural sites. We've identified a number of facilitators as well as barriers, and the hope is that by optimizing the facilitators and minimizing the barriers, we can improve implementation for teledermatology in the VA in the future. With that, I'll thank all of my collaborators on this, as well as the VA, for supporting this work.